Can you give an overview of mild cognitive impairment and how that's different from dementia disorders and Alzheimer's disease?
No. Matters of nomenclature, naming in this disease are uniquely challenging, which is fascinating given how common it is compared to all the other top common diseases of aging, cardiovascular disease, cancer. There's such spectacular confusion. And essentially, the whole first part of the problem of Alzheimer's, called Part 1, Alzheimer's Unbound, is all about essentially nomenclature, albeit, I think, told through stories. Namely, once upon a time, you had to have dementia to be diagnosed with Alzheimer's disease. Meaning, if you didn't have dementia, there's no way you could be diagnosed with Alzheimer's, because that described sort of the presentation of the disease. So what's dementia? Disabling cognitive impairments. So someone who previously was cognitively unimpaired has begun to develop slow declines, losses in memory, attention, concentration, executive function, language, and they're disabling. They can't do their usual and everyday activities, managing money, transportation, shopping, etc. Long before troubles with bathing, dressing, grooming. That's dementia. And that sort of structure, first say they have dementia, then decide based on the history and exam that the cause is Alzheimer's disease as opposed to Lewy body disease, Parkinson's disease, normal pressure hydrocephalus. That world worked, and that's what I was trained in. And then, as I chronicle in the book, something revolutionary happened in the field pretty much in a short space of time, sort of from like about 1999 to 2010. That 10-year period, namely the discovery of this idea that there was a clinical state that described individuals who were not demented, but had cognitive impairment that put them at higher risk of progressing to dementia caused by Alzheimer's. And that was this idea of what has come to be called mild cognitive impairment, known most commonly by its shorthand, MCI. And I chronicle in the book the discovery, if you will, of the MCI construct by physicians and researchers at the Mayo Clinic. And I point out, I think I make great effort to point out how it really was dependent on the Mayo Clinic's uniqueness that made MCI, that discovered MCI. So MCI essentially describes clear changes in cognition noticed by others, experienced by the individual, detectable on testing, albeit it's a harder testing set to do than dementia testing in terms of the subtleties of it. But then just inefficiencies in daily activities. I think that's the key word, is inefficiencies. People complain of taking longer, etc. They're not disabled, they're inefficient. Do all people with MCI develop dementia? No, but you're certainly at heightened risk of developing dementia.
Now, you mentioned not all people with MCI go on to develop dementia, but do you have a
That's
sense
exactly
of the
right.
percentage?
Yeah, well, it depends. That's where MCI became tough, because in the hands of skilled clinicians who have the time and resources of a Mayo Clinic clinician, you could see MCI as this 15% per year risk, such that by 5 years, 50% have transitioned, declined, pick your word, from MCI to dementia. The other 50% haven't. When MCI was put out into wider practice, you saw more variable rates of conversion. And a lot of that comes with the subtlety, if you will, of the diagnosis and the criteria one uses to decide that there is cognitive impairment, etc. But again, when you look across multiple studies that use reasonably reproducible criteria to define what is mild cognitive impairment, you kind of find this sort of 10 to 15% per year risk that an individual with MCI will decline and have disabling cognitive impairments and meet criteria for dementia. When you think about risk, that's a pretty high risk. I mean, if you told me I have something where I have a 10% risk of getting a disease like Alzheimer's, that's not a trivial risk. It's not unavoidable, but it's not trivial. Yeah.
So say there are people in that MCI range, and what can they do to prevent that risk or reduce the risk or slow down conversion to dementia? Are
Yeah.
there things?
Well done studies, large, well done studies in the US and other countries that have been conducted for many years, decades even, are showing the same consistent finding, that over the last 40 years, the risk of developing dementia has been declining. Meaning, we thought the risk was this, but it's actually lower. It's still a risk. And because there's so many older adults, there's so many people with dementia. but we're not seeing the rates that we thought we would see. And so the question then becomes, well, what's going on? And the answers to that also are very consistent. And I kind of like to summarize it with simply sort of two words, which is access and opportunity. So we see a life course perspective here for reducing the risk of dementia. Access, or opportunity, excuse me, starts with education. I mean, there's relentlessly consistent data that individuals who have at least about a high school level of education, a quality education at high school level, have a reduced risk of developing dementia later in life compared to people who don't have that quality and length of education, which gets to issues, of course, of the quality of education, not just the years of it. That's a consistent finding. And we think that we talk about the cognitive reserve hypothesis for that, but also, of course, the opportunity that comes from having an education in terms of social and economic opportunity. That said, the data are also very consistent that brain health is maintained in individuals who maintain heart health. And across multiple studies, the similar story that you hear, that you see, is individuals who developed cardiovascular disease but had access to care and or otherwise were able to reduce the risks of cardiovascular disease are in the group of individuals with a lower risk of developing dementia. And I think that's a very important story in the United States of America, because cardiovascular disease tends to, though not consistent, it tends to be a disease that's sort of more middle-aged to older. I'm not saying older adults have cardiovascular disease, they certainly do. But the story here then is the ability in middle age to have access to healthcare and heart health care really is going to reduce your later life risk of developing dementia. And then a third point is we've begun to identify a host of activities in life that are associated with a lower risk of dementia, other than in addition to the activities that maintain heart health. And actually, I think a great site to learn more about that is the AARP's Global Council on Brain Health. It's a very useful, summative assembly of the data around physical activity, social engagement, diet, supplements. What do we know, and what is really the evidence to support or not support whether they actually maintain brain health? And I would recommend to your listeners the Global Council on Brain Health's website to really learn what can I do to maintain my brain health.